This is Kathy Knipfer, instructor for Nursing 2203, recording the pediatric lecture for Chapter 48, Musculoskeletal or Articular Dysfunction. One of the most difficult aspects of illness in a child is immobility. Frequent reasons for immobility include congenital defects, degenerative disorders, infections or injuries that impair integumentary, neurologic, or musculoskeletal systems, and also therapies that prolong immobilization. Table 48-1 that begins on page 1532 provides a comprehensive summary of the physiologic effects of immobilization, starting with the muscular system, where it causes a decreased muscle strength and mass. It causes atrophy and a loss of joint mobility. It also affects the skeletal system with bone demineralization and negative calcium balance. Immobilization affects metabolism. It causes decreased metabolic rates, a negative nitrogen balance, hypercalcemia, and a decreased production of stress hormones. Immobility also affects the cardiovascular system. It causes decreased efficiency of the orthostatic neurovascular reflexes. It causes diminished vasopressor mechanism, altered distribution of blood volume, also venous stasis and dependent edema. Effects of immobility on the respiratory system include a decreased need for oxygen, a diminished vital capacity, poor abdominal tone and distension, mechanical or biochemical secretion retention, and loss of respiratory muscle strength. Immobility also affects the gastrointestinal system. There is distension that's caused by poor abdominal muscle tone, difficulty feeding in the prone position, gravitation effect on feces, as well as anorexia. The effects of immobilization on the urinary system include an alteration of the gravitational force, difficulty voiding in the supine position, urinary retention, as well as impaired ureteral peristalsis. For the integumentary system, there is decreased circulation and pressure, leading to a decreased healing capacity. Psychologic effects of immobilization include diminished environmental stimuli, altered perception of self and environment, increased feelings of frustration, helplessness, and anxiety, depression, anger, aggressive behavior, as well as developmental regression. Immobilization of a child definitely disrupts the family function. For extended periods of immobilization, logistic management of the sick child is required. There is a need for family support and home care assistance. They may need assistance with coping skills. Individual and group counseling may be helpful, as well as parent groups. Traumatic injury may involve those to soft tissues such as muscles, ligaments, and tendons. They may occur as a result of mishaps during play or sports injuries. This diagram shows examples of traumatic injuries like sprains and strains, contusions, dislocations, separations. Contusions may involve damage to soft tissue, subcutaneous tissue, and muscle. The blood escapes into the tissues and causes ecchymoses, or the black and blue discoloration. They result in swelling, pain, and disability, and they may occur as a result of crush injuries. Dislocation is a displacement of the normal position of opposing bone ends, or of bone ends to the socket. It occurs when the force of stress on the ligament is sufficient to cause displacement. Pain increases with active or passive movement of the affected extremity. With hip dislocation, there is a potential loss of blood supply to the head of the femur. The best outcome occurs if the bone is relocated within 1 hour. A sprain is trauma to a joint from a ligament that is partially or completely torn or stretched by force. It may be associated with damage to blood vessels, muscles, tendons, and nerves. The presence of joint laxity is the indicator of severity. There is a rapid onset of swelling with the disability. A strain is a microscopic tear to the musculotendinous unit. It is similar to a sprain. The area is swollen and painful to the touch. It is generally incurred over time. The more rapidly the strain occurs, the more severe the injury. RICE and ICES are acronyms for the therapeutic management of soft tissue injuries. The R stands for resting the injured part. The I stands for ice, immediately, for a maximum of 30 minutes at a time. The C is for compression with wet elastic bandage. E is for elevation of the extremity. When the S is added, it stands for support. So that might involve casts or splints, depending on the injury. Fractures are common injuries in children. The methods of treatment are different in children than in adults because the fractures heal faster. Fractures are rare in infants. If there are fractures, it would warrant investigation. The distal forearm is the most frequently broken bone in childhood. For school-age children, these injuries are usually related to a bicycle or a sports injury. Now let's talk about the types of fractures. There are simple or closed, where there is not a break in the skin. Open or compound, where the fractured bone protrudes through the skin. Complicated fractures are where bone fragments have damaged other organs or tissues. Comminuted fractures are where small fragments of bone are broken from the fractured shaft and they lie in the surrounding tissue. Here's a diagram of the types of fractures in children. Fracture lines can be described as transverse, where they occur crosswise at right angles to the long axis of the bone. They can be oblique, where they slant, but they're straight between a horizontal and a perpendicular direction. They may spiral, where they are slanting and circular, twisting around the bone shaft. The weakest point of long bones is the cartilage growth plate, or the epiphyseal plate. It is a frequent site of damage during trauma, and it may affect future bone growth. The treatment may include open reduction and internal fixation to prevent growth disturbances. The Salter-Harris classification is used to classify these growth plate injuries or fractures. Here's a diagram of the Salter-Harris fracture classification. You can refer to Figure 48-3 on page 1538. Bone healing and remodeling occurs more rapidly in children. During the neonatal period, it usually takes 2 to 3 weeks. For early childhood, 4 weeks. Later childhood, 6 to 8 weeks. And then adolescence, it's 8 to 12 weeks. Diagnosis and management of fractures. Diagnostic evaluation is made through radiographs or x-rays, history taking, and then just the suspicion of a fracture in a young child who refuses to walk or bear weight. The goals of fracture management include reduction of the fracture and immobilization, restoring function, and preventing deformity. There are 6 P's that should be assessed with fractures: pain and point of tenderness, pallor, you would look at the skin to see if it's pale, which would indicate poor perfusion. You would be concerned if the capillary refill was greater than 3 seconds. You would also check pulselessness distal to the fracture. Paresthesia, you would check sensation distal to the fracture site and check for tingling or burning. You would also check paralysis. by checking movement distal to the fracture site. Pressure, you would check the skin to see if it's warm or tense or tight or shiny. You would use these same 6Ps if you were evaluating for compartment syndrome. Casting for fractures. Casts may be made of plaster, fiberglass, or polyurethane resin. Plaster of Paris takes a while to dry, while fiberglass dries quickly. The cast must remain uncovered to allow it to dry from the inside out. Heated fans or dryers should not be used. A regular fan or a cool air hair dryer to circulate air may be helpful when the humidity is high. During the first few hours after a cast is applied, the chief concern is that the extremity may continue to swell to the extent that the cast becomes a tourniquet and shuts off circulation. This is called compartment syndrome. It also produces neurovascular complications. Appropriate cast care guidelines should be given prior to discharge. You should refer to the patient teaching box on cast care on page 1541. Casts are removed with a cast saw that has an oscillating blade. This may be scary for the child, so it would be important to prepare them for this procedure. Skin care after removal of a cast includes soaking in a tub to remove the secretions and the cells that build up on the skin. An application of mineral oil, baby oil, or lotion may help to remove these particles. Here's an example of a fiberglass hip spica cast. Sometimes traction is used for fractures. In children, most balanced skeletal traction is applied to allow physiologic stability, align bone fragments, and enable closer evaluation of the injured site. Newer technology involves orthopedic fixation devices that allow for mobility. Purposes of traction include relieving fatigue in involved muscles, positioning distal and proximal bone ends, immobilizing the fracture site, preventing deformity, immobilizing the healing bone and preventing further injury, as well as reducing muscle spasms. This diagram shows how traction works, with the traction, which is the forward force, and the counter traction, which is the backward force. Types of traction. Traction may be applied to the upper extremity, but this is uncommon in children. It is usually applied to the lower extremity in children. Examples would be Bryant traction, where the pull is in only one direction, Buck extension, where the legs are in an extended position. Russell traction consists of two lines of pull. There is skin traction on the lower leg and a padded sling under the knee. Balance suspension suspends the leg in a desired position to relax the hip and hamstring muscle. It does not exert traction directly on a body part. Cervical traction with a halo brace or vest is for displaced or fractured cervical vertebrae. Gardner-Wells tongs, which are spring-loaded, do not require burr holes or shaving, and they're also used with a halo vest. See the traction care guidelines on page 1545. Here's an example of Buck extension traction. Here's an example of a halo vest. Distraction of fractures is a process of separating opposing bone to encourage regeneration of new bone in the created space. It can be used when limbs are unequal in length and new bone is needed to elongate a shorter limb. An external fixation device is commonly used. This is a child with an external fixation device used for distraction for fracture. Amputation of a limb may be due to a congenital absence, traumatic loss, or a surgical amputation. Surgical repair of a severed limb is performed to construct an adequately nourished residual limb. The stump is shaped using a figure-8 configuration with an elastic bandage. This creates a cone shape, reduces edema, and controls hemorrhage. The stump should only be elevated for the first 24 hours to prevent contractures. If the patient has a prosthetic, the stump should be washed with soap and water every day. The skin should be inspected, and the prosthesis time should be adjusted to avoid skin breakdown. Pain management includes a discussion of phantom pain, and the nurse should determine any sources of pain. Overuse syndromes. Young athletes are forced to train longer, harder, and earlier in life. Performing the same movements repeatedly can cause microtrauma and inflammation. This may involve friction or rubbing, traction or repeated pulling on a ligament, cyclic or repetitive loading of impact forces, which causes stress fractures. The treatment includes rest, using an alternate exercise, alleviating repetitive stress, taping, bracing, splinting, cold application. Developmental dysplasia of the hip, or DDH, was formerly called congenital hip dysplasia, or congenital dislocation of the hip. It occurs in 1.5 per 1,000 live births. It most commonly affects girls, and there's a strong family history. This diagram shows the normal hip, as well as dysplasia, subluxation, and dislocation of the hip. There are 3 degrees of DDH, or developmental dysplasia of the hip. The mildest form is acetabular dysplasia, or preluxation. It consists of osseous hypoplasia of the acetabular roof, and the femoral head remains in the acetabulum. Subluxation is the incomplete dislocation of the hip. With dislocation, the femoral head loses contact with the acetabulum and is displaced posteriorly and superiorly. Ligaments are elongated and taut. Clinical manifestations of DDH. In the infant, there's hip joint laxity, there's a shortened limb on the affected side, there's restricted abduction of the hip on the affected side, and also unequal gluteal folds when the infant is prone. You would see a positive Barlow test result, which is hip dislocation by adduction, and then positive Ortolani test result, which is hip dislocation by abduction. Here you see the signs of developmental dysplasia of the hip. You can refer to page 1549 for more information. Therapeutic management of DDH. It's important for early intervention to occur. Between birth and age 6 months, a Pavlik harness is applied for abduction of the hip. For ages 6 to 24 months, the dislocation may be unrecognized until the child begins to stand and walk. The treatment would be close reduction and spica cast. With the older child, an operative reduction is performed, also a tenotomy and osteotomy. Correction is very difficult after the age of 4. Here's the Pavlik harness, which is used in the infant for treatment of DDH. Clubfoot is a complex deformity of the foot and ankle. There are different types. Talipes varus is an inversion or bending inward. Talipes valgus is an eversion or bending out. Talipes equinus involves plantar flexion with the toes lower than the heel. Talipes calcaneus is dorsiflexion with the toes higher than the heel. Another type of clubfoot is Talipes equinovarus, where the toes are lower than the heel and they face inward. There are also different classifications of clubfoot. They may be positional, which would be mild or postural. They may correct spontaneously or necessitate passive exercise or serial casting, but there's no bony abnormality. Syndromic or tetralogic is associated with other congenital anomalies. It usually necessitates surgical correction and there's a high incidence of recurrence. Congenital or idiopathic clubfoot involves a bony abnormality and it always necessitates surgical intervention. Therapeutic management of clubfoot includes 3 stages: correction of the deformity, maintenance of the correction until normal muscle balance is regained, and follow-up to avert possible recurrence. The Ponseti method, or serial casting, usually involves a percutaneous heel cord tenotomy. Here you see an infant with feet casting for bilateral clubfoot. Skeletal limb deficiency. It's also called reduction malformation. It comes in a wide range of severity, but involves underdevelopment of skeletal elements. There may be a prenatal destruction of the limb through a constriction by an amniotic band. Other associated abnormalities may be present. Types of limb deformities. Amelia is the absence of an entire extremity. Macromelia is the partial absence of an extremity. Phocomelia is a deficiency of long bones with relatively good development of the hands and feet. They're attached at or near the shoulder or the hip. They're also called seal limbs. Therapeutic management of limb deformity. It is important to use prosthetics as early as possible to encourage maximum exploration and development in infancy. Phocomelic digits may be surgically modified and preserved and reattached for use with prosthetics. Osteogenesis imperfecta is the most common osteoporosis syndrome of childhood, but it's very rare. It is a group of heterogeneous inherited disorders of connective tissue. It's characterized by excessive fragility and defects of bone. There is defective periosteal bone formation and reduced cortical thickening of bones. There's also a hyperextensibility of ligaments. You can refer to page 1553 and box 48-6 for more. The therapeutic management of osteogenesis imperfecta is primarily supportive. Treatment with intravenous bisphosphonate therapy promotes bone density and prevents fractures. The nurse may rule out osteogenesis imperfecta if a child has multiple fractures, such as in a child abuse investigation. Rehabilitation focuses on prevention of positional contractures and deformities, muscle weakness and osteoporosis, as well as malalignment of the lower extremity joints. Braces, splints, physical therapy are commonly used. Would these infants and children be more fragile? Yes. They would require careful handling to prevent fractures. Leg-Calvé-Perthes disease is an aseptic necrosis of the femoral head. It is self-limiting, idiopathic, and occurs in children between the ages of 2 and 12. It most commonly occurs in white males ages 4 to 8 years. 10% of the cases have bilateral hip involvement. There is a delayed bone age in most cases. The cause is unknown, but it results in disturbed circulation to the femoral head, thus the aseptic necrosis. This disease has an insidious onset. There is a possible history of a limp, soreness, or stiffness, limited range of motion, and a vague history of trauma. The pain and the limp are most evident on arising at the end of activity. The diagnosis is based on the history and findings on radiographs and MRI. After resolution, the femoral head may be normal or have severe alteration. The treatment goal for leg Calvé-Perthes disease is to keep the head of the femur in the acetabulum. Containment is maintained with various appliances and devices. Treatment would involve rest and no weight bearing initially. The patient may be treated with NSAIDs. Surgery may be a part of the treatment in some cases, as well as home traction. Slipped capital femoral epiphysis is also known as coxa-vara. It involves spontaneous displacement of the proximal femoral epiphysis in a posterior inferior direction. The femoral head becomes deformed and blood vessels are stretched. It develops most frequently shortly before the onset of puberty, between the ages of 9 and 16. 40 to 60% of the cases have bilateral involvement. It is most frequently observed in boys and in obese children. See box 48-8 on page 1555. Kyphosis is an abnormally increased convex angulation in the curvature of the thoracic spine. The most common form is postural. It can result from tuberculosis, arthritis, osteodystrophy, or compression fracture. See B of figure 48-15 on page 1556. Lordosis is an accentuation of the cervical or lumbar curvature beyond physiologic limits. It may be idiopathic or secondary as a complication of trauma. It may occur with flexion contractures of the hip and congenital dislocated hips. In obese children, it's caused by an alteration in the center of gravity by abdominal fat. See C of figure 48-15 on page 1556. Idiopathic scoliosis is the most common spinal deformity. It is a complex spinal deformity that occurs in 3 planes. There's a lateral curvature, a spinal rotation causing rib asymmetry, as well as a thoracic hypokyphosis. It may be congenital or developed during childhood. In this diagram, you can see the associated curvatures of kyphosis, lordosis, and scoliosis. Idiopathic scoliosis has multiple potential causes. Most cases are idiopathic in nature. It generally becomes noticeable after the pre-adolescent growth spurt. Clothes may be ill-fitting. The use of school screening is controversial. Studies have not shown improved outcomes because those performing the screenings must be trained. They must have consistent and proper training. Spinal curvatures are diagnosed through standing radiographs to determine the degree of curvature. The practitioner may see asymmetry of shoulder height, scapular or flank shape, or hip height. In addition to the primary curve, There may be a compensatory curve that is often present to align the head with the gluteal cleft. Therapeutic management of spinal curvatures involves a team approach. It also involves bracing in conjunction with exercise. Surgical intervention may be necessary for severe curvature. This involves insertion of instrumentation and fusion. It may be a specific type of rod that's inserted, such as a Harrington rod or a Luke rod. Here are some examples of bracing for spinal curvatures. When managing care of the patient with a spinal curvature, the nurse should address concerns of body image and of prolonged treatment of the condition. Preoperative care includes teaching, planning for blood loss, as well as PCA training or patient-controlled analgesia. Postoperative care includes skin care, neuroassessment, duodenal compression obstruction issues, so you would recommend the use of the left lateral decubitus position, range of motion. These patients usually ambulate by the second or third day and are discharged by 1 week. Family issues also need to be addressed. The nurse should encourage participation in care as well as support groups. Osteomyelitis is an infectious process in the bone. It may be caused by an exogenous or direct inoculation or a hematogenous or bloodborne source. Staph aureus is the most common causative organism. Other types of osteomyelitis include subacute, which has a longer course and may be caused by less virulent organisms. It may have a walled-off abscess. The chronic type is an acute osteomyelitis that progresses and is characterized by dead bone, bone loss, drainage, and sinus tracts. Osteomyelitis begins abruptly. It resembles symptoms of arthritis and leukemia. See box 48-9 on page 1559. There is marked leukocytosis and an increased ESR, or sedimentation rate. Blood, joint fluid, and infected skin cultures are obtained. Bone cultures are obtained from biopsy or aspirate. Radiographs may appear normal at first. Bone scans are needed for diagnosis. Therapeutic management of osteomyelitis. The presentation may be subacute with the walled-off abscess rather than a spreading infection. It requires prompt, vigorous intravenous antibiotics for an extended period, 3 to 4 weeks or up to several months in length. It would be important for the nurse to monitor hematologic, renal, and hepatic responses to treatment. Care management of osteomyelitis includes complete bed rest and immobility of the limb. The nurse should also address pain management concerns. The patient will need long-term intravenous access for the antibiotic administration. There are also nutritional considerations. They may require a long-term hospitalization and therapy. Psychosocial needs are important. It would be important for the nurse to provide diversional activities. Septic arthritis usually results from hematogenous spread or direct extension from an existing adjacent cellulitis or osteomyelitis. It may involve any joint, but most commonly it occurs in the hip, knee, ankles, and elbows. It usually only involves one joint. Clinical manifestations of septic arthritis include severe joint pain, swelling, warmth of the overlying tissue, and occasional erythema. It frequently follows a traumatic injury. The nurse might also see fever, leukocytosis, and increased sedimentation rate. Neisseria gonorrhea is the frequent cause of septic arthritis in sexually active teenagers. Diagnosis of septic arthritis is based on results of blood culture, joint fluid aspirate, and radiography. Treatment involves intravenous antibiotic therapy, pain management, surgical intervention for wounds, and physical therapy. Skeletal tuberculosis. It is a lymphohematogenous dissemination of pulmonary tuberculosis that may result in tubercular infection of the bones and joints. That's a mouthful. Common sites are the fingers and the toes, also called tubercular dactylitis. Also spinal erosion or Pott's disease. Knees, joints. This causes destruction of adjacent bone. It is not common in the United States, but it should be suspected if it is in a community with a high incidence of TB. The index case should be located, or the primary case. Bone and soft tissue tumors. Osteosarcoma and Ewing sarcoma account for 90% of all primary malignant bone tumors in children. They occur more commonly in boys. The incidence is highest during the accelerated growth rate of adolescence. The incidence peaks at 15 years of age. When diagnosing bone and soft tissue tumors, it would be important to rule out trauma or infection first. Definitive diagnosis is based on findings on radiologic studies, such as computed tomography scans or bone scans and bone biopsy. The MRI helps to evaluate neurovascular and soft tissue extension. Laboratory tests are also done. Alkaline phosphatase levels are elevated with some bone tumors. Osteosarcoma or osteogenic sarcoma is the most frequent malignant bone tumor type in children. The peak incidence is in the second decade of life. Most primary tumor sites are in the diametaphyseal region of the long bones. Most cases are in the distal femur. Other sites include the humerus, tibia, pelvis, and jaw. The traditional approach to manage osteosarcoma would be a radical surgical resection or amputation of the affected area. Limb-salvage procedures may be possible where the bone is resected and a prosthesis replaces the affected area. Chemotherapy may accompany the surgical treatment. Preoperative preparation is essential when managing care of a patient with osteosarcoma. These patients require support during the adjustment to the concept of an amputation, surgical resection, and a life-threatening diagnosis. Adolescents have body image concerns. These patients should also be taught about pain management and the concept of phantom limb pain. Ewing sarcoma is a primitive neuroectodermal tumor. It is the second most common malignant bone tumor in children and adolescents. It is rare after age 30. It usually affects Caucasians. It arises in the bone marrow, especially in the femur, tibia, ulna, humerus, vertebrae, pelvis, scapula, ribs, and skull. Radiation is the most common first approach for treating Ewing sarcoma. Chemotherapy may be an adjunct to radiation. Surgical resection may take place in some cases. They are usually able to preserve the affected limb. The prognosis is best if there is no metastasis at the time of diagnosis. Nursing includes managing complications of radiation and chemotherapy and addressing nutritional concerns throughout the treatment regimen. Rhabdomyosarcoma is a malignant neoplasm that originates from undifferentiated mesenchymal cells in the muscle, tendon, bursa, and fascia, or in fibrous connective lymphatic or vascular tissue. The name reflects the tissue of origin. Myo means muscle, rhabdo means striated. Potential sites of rhabdomyosarcoma include the orbit, nasopharynx, paranasal sinuses, middle ear, the retroperitoneal area, and the perineum. See Table 48-2 on page 1563. When diagnosing rhabdomyosarcoma, The signs and symptoms depend on the site of the tumor and the compression of adjacent tissues. If there's a tumor in the orbit, symptoms occur early in the course of the disease. This leads to rapid diagnosis and improved prognosis. A tumor in the retroperitoneal area causes minimal symptoms until the tumor is large and invasive. Many symptoms are vague and common to other childhood maladies, such as an earache. Rhabdomyosarcoma is highly malignant and frequently metastasizes. Complete removal of the tumor is important. Radiation therapy is used for most tumors. Chemotherapy may be used to shrink the tumor, and it may precede radiation therapy. They may be required to take long-term chemotherapy for 1 to 2 years. Juvenile Idiopathic Arthritis. This is formerly known as juvenile rheumatoid arthritis, also called idiopathic arthritis of childhood. It is a chronic autoimmune inflammatory disease. It may be caused by immunogenic susceptibility and possibly an environmental trigger, such as a virus. The peak onset is 1 to 3 years of age, and it's often undiagnosed. 90% of affected children have a negative rheumatoid factor. For symptoms, they may burn out and become inactive. This disease involves a chronic inflammation of the synovium with joint effusion, destruction of cartilage, and ankylosis of joints as the disease progresses. There are no definitive diagnostic tests for juvenile idiopathic arthritis. It is classified according to the Durbin classification of JIA, juvenile idiopathic arthritis. There is an elevated sedimentation rate in some cases. Anti-nuclear antibodies are common, but not specific for JIA. Leukocytosis occurs during exacerbations. The diagnosis is based on criteria such as age of onset before age 16, arthritis in 1 or more joints for 6 weeks or longer, and exclusion of other causes. There is no specific cure for JIA. The goals of therapy are to preserve function, prevent deformities, and relieve symptoms. These patients are treated primarily as an outpatient. With respect to pharmacology for JIA, these patients may be treated with nonsteroidal anti-inflammatory drugs, slow-acting anti-rheumatic drugs, corticosteroids, cytotoxic agents such as methotrexate, and biologic agents. Care management of JIA includes physical therapy and occupational therapy, relief of pain, promotion of general health, facilitating compliance, encouraging the use of heat and exercise, and supporting the child and family. Systemic lupus erythematosus, or SLE, is a chronic, multi-system autoimmune disease of the connective tissues and blood vessels. It's characterized by inflammation. As you know, the symptoms are variable and unpredictable. The symptoms may be mild or they may be even life-threatening. SLE is more common in girls and women between the ages of 10 and 19. It's more common in African American, Asian, and Hispanic children, but it's reported in all cultures. There's a familial tendency and an unknown cause. Possible triggers include hormone imbalance, immune disorders, environmental exposure to drugs, infection, stress, and chemical agents. Clinical manifestations of SLE include cutaneous lesions, lymphadenopathy, nausea, vomiting, diarrhea, and pain, generalized weakness, arthritis, joint pain and stiffness without deformity, forgetfulness, seizures, paralysis, pleurisy, pericarditis, proteinuria, as well as renal failure. The goals of treatment for SLE include balancing medication at a level to avoid exacerbations while minimizing treatment-associated complications. Pharmacology may include steroids, NSAIDs, anti-malarial drugs for rash and arthritis, and other immunosuppressives. Care management includes encouraging them to comply with therapy, helping them adjust positively to the disease, minimize exacerbations, and to teach them regarding nutrition, sleep, rest, exercise, and to limit their sun exposure.